Good afternoon. Thank you very much to everyone for actually traveling from all parts of the region here. As thank you for the local press as well for making time to come today. So today is an important day for us because I think we want to introduce to you some new developments in the Parkway Cancer Center Stem Cell Transplant Program. And to do what I want to do today in the next 30 minutes is outline to you some of the recent changes and developments in the field of transplantation over the last 10 years. But before that, I understand it's quite a complex field. Many of you may not be that familiar with the field, so I will provide some background as well into what stem cell transplantation involves from there. Yeah. So just to start with, I thought it would be important, not before we start talking about Singapore, is just to give you a global perspective of where we are in terms of the technology and the development in terms of the field of stem cell transplantation in the region. Yeah. So worldwide, it's important to realize that, transplantation we like to think of as a very bespoke and very rare, a very highly sophisticated transplant procedure. And yes, it is very sophisticated, it's high risk, but actually the amount of transplants that have been done worldwide has been steadily increasing since the first bone marrow transplantation was done in 1957. So if you look at it, in the end of 2012 actually, somewhere in the world, the first 1 millionth transplant was actually done in the world. So 1 million, more than 1 million transplants have actually now been done worldwide. But one of the important things is you look at it, it's the distribution of transplants. Where have they been done worldwide? And this chart shows data from 2008. And things have changed slightly, but the figures are still largely representative. And if you can look, one of the key things is that if you look at transplantation in Asia alone, 6,500 transplants were performed in Asia during that period. It pales significantly in number compared with the number of transplants done in Europe and the number of transplants done in America. So in terms of the population of Asia, the number of transplants we're doing, you could say, is significantly lower than the number of patients who potentially can benefit from this. And why is this the case? So there's several reasons why. So one of the reasons is there's a lack of facilities, good transplant facilities in the region. There needs to be more of them so that we can do more transplants. Certainly, there's also a need to have experienced transplant doctors as well as transplant nurses so that we can do more of these procedures and do these procedures well. And the other important thing, which I'm going to talk more about later on in my talk, is actually how do we make transplants more accessible to the patients? And to make transplants more accessible to patients, there are several hurdles that we need to overcome as a community. Firstly, we need to find ways to allow more patients to benefit from donors. We need to find ways to make transplants cost-effective. Certainly, transplants are high-cost procedures, but there are measures we can do, particularly in the adult setting, to try to make the procedures as cost-effective as possible for the patients. And finally, of course, we need the transplants to be successful, because there's no point trying to get people to have transplants if we cannot show that our outcomes are improving as we go along. Okay? So a bit of background to stem cell transplantation then, yeah? There are different types of stem cell transplants, and I will proceed to explain to you what these different types of transplantations are later on. There's autologous stem cell transplantation, allergenic stem cell transplantation, as well as transplantation where we use stem cells from different sources, such as cord blood transplant or haploidentical transplant, which I'm going to elaborate a bit more later on. So transplants can be used for many different indications. So who benefits from transplants? Yeah. So basically, you can group them into patients who have cancers, so mainly blood cancers, but some solid tumors may benefit from some transplants as well. But there's also a whole group of disorders which are non-cancer, non-malignancies, which may benefit from transplant, particularly children, for example, with red cell disorders, for example, like thalassemia and sickle cell disease, which is quite common in many parts of the region. They are children who may benefit from a transplantation as a curative procedure. All in all, if you look at the literature, you look at all the recommendations worldwide, there are actually almost 70 different types of diseases which may benefit from stem cell transplantation. Although, to be honest, in Singapore and many other regions, we tend to focus on the more common indications, which tends to be blood cancers, occasionally some solid tumors, as well as red cell problems. So what does stem cell transplantation involve? So I'll take a few steps back to just run through some of the background for that for you. So stem cell transplantation, we need to get the stem cells, and in stem cell transplantation for bone marrow, particularly bone marrow stem cells. And bone marrow stem cells are usually only found in the middle of the bone marrow. So I'm sure all of you have eaten a chicken bone or a oxtail, and you find that there's a bone marrow, there's a bone, which is a hard white part, and in the middle, there's a spongy red bit usually. And some of you may like to suck it up and eat it, a lot of fat there. But that contains all the stem cells that make the blood from there. But actually, if you look at it, stem cells only make up a very small proportion of all the cells in the bone marrow. So actually, out of 1,000 cells in the bone marrow, only one's really what we call a true stem cell. And those are the stem cells which can divide and grow with time and become all the different types of cells that make up your blood. How do we extract the stem cells? So that's the first thing. Before we actually do a bone marrow transplant, we need to be able to extract the stem cells out from the bone marrow so that they can grow in another patient. So there are three common ways in which we get stem cells. Okay? Nowadays, in 85% of cases, we get stem cells from the blood of a donor by a procedure called peripheral blood stem cell harvesting, or apheresis. And I'll show you the picture of that. There's a machine which I'll show you afterwards, and actually, if you're lucky, there's a patient who's still undergoing the procedure in Novena that you may get to see afterwards from there. There's another option, which is bone marrow harvesting. And finally, umbilical cord blood is also a source of stem cells. So bone marrow harvesting, this used to be the main source in which we did stem cell harvesting. This is a procedure where usually a patient is put under general anesthetic, lies down, face down on a theater bed, and usually one or two doctors will take bone marrow blood out from his back. And usually we take anything from 500 mils to up to more than a liter of blood, depending on who the donor is from there. Yeah? And we still do it for many indications from there. But it is sometimes a bit more uncomfortable for the patient. More recently, we moved to this machine, which we call an apheresis machine. So increasingly, we're able to take stem cells out from the blood of patients instead. So this is more of an outpatient procedure. Patients are on this machine for usually 2 to 3 days from there. And I'll just show you the picture of this machine, which we have actually in our setting, which is the latest state-of-the-art machine, which allows us to harvest patients very quickly from there. So this is how we do many of our harvests. And finally, one of the other ways we can get stem cells is actually in the cord blood. So when babies are delivered, attached to the placenta is the cord, and the blood within the cord is actually a very rich source of stem cells. So for many years now, what we've noticed, what we know that we can do is actually, if we drain the blood out from the cord and you store it, you can actually potentially reinfuse it to patients later on who need a stem cell transplant. So that's another way in which we can do it. The advantage to this is that there are cord blood banks stored around the world. One of the challenges with this is, the cost of storage is quite significant from there. So whenever we need to get cord blood from these places, sometimes it can be quite costly from there. So once you get the stem cells harvested from a donor or a patient, there are two main types of transplants we can do. There's an autologous stem cell transplant. Autologous stem cell transplant basically means that we get the stem cells away from the patient themselves. And so what happens is that we harvest the patient's stem cells before we want to give them a very strong dose of chemotherapy. So we take the stem cells away, keep it. Then we can give patient very strong amounts of chemotherapy, which will decrease all the blood cells in their body. But what we can do then is once the cells are reduced in the body by the chemotherapy, we can rescue the patient by giving them the stem cells back. And by doing that, the patient can recover quickly from that point of view. Because if we don't give them stem cells back, many of these patients will have low counts for a very long time and will be very prone to infections from there. So that's autologous stem cell transplants. So we use the patient's own cells. It allows us to give patients high doses of chemotherapy. The autologous stem cells can rescue the patient from the side effects and limit the side effects of treatment. And it's a fairly low-risk procedure. So with adult transplants, the risk of complications from this is in the order of 1 to 2% risk of actually dying in the first 3 months after this procedure. Still significant, but it's still, in terms of cancer, it's a fairly low-risk procedure from there. But the majority of transplants we tend to do in our institution, with me, tend to be allergenic stem cell transplants. Allergenic stem cell transplants tend to be a slightly higher risk procedure. because we're getting stem cells from another person. Yeah, this may be stem cells from a matched sibling, so a brother or a sister, but may also be stem cells from an unrelated donor from anywhere, either in Singapore or around the world where we can find a match. Or, as I showed earlier picture, we can get it from cord bloods, or, as I'll touch on later, haploidentical donors. And what we do in these cases is that we take cells from a donor and we store the cells first. The cells that we store from a donor, we can actually do several things for it nowadays. So sometimes we will give the donor cells directly back to a patient, but increasingly there's technology available where sometimes we will actually take stem cells from a patient donor and we'll actually process the stem cells to remove some cells that we think may be harmful, or we can actually modify a donor's stem cells as well before reinfusing them. But we give the patients, so we take cells from the donor away, we then treat the patient with chemotherapy, and once the patient's been treated with chemotherapy, we will give the donor cells back to the patient. The thing with allergenic transplants is that generally patients stay in hospital for a period of around 4 to 6 weeks, because during the period where we're waiting for the donor cells to recover, generally patients' immune system is extremely low and they need to be housed in a very protective environment. So afterwards we'll show you in Novena, for example, the new transplant rooms we have are purposely built with filtered air, with airflow, as well as positive pressure. And all these measures are to make sure that the patients are kept as safe as possible during this period when they need an allergenic stem cell transplant. So I've told you a bit about what stem cells are, what the different types of stem cell transplants are. I know it's a very brief run through, and I'm happy to answer more questions afterwards about it. But I just want to show you how transplantation has come along in terms of improvement in outcomes over the last 10 years. And the improvement in outcomes of stem cell transplant stems for a variety of reasons. I think transplant physicians are getting more experienced. The experience of a transplant team is still very important in determining the outcome of patients, partly because there are changes in new drugs which are available for transplantation. And you need experience to choose the type of drugs for different patients. And unlike some forms of chemotherapy, quite often for stem cell transplants, the type of chemotherapy you give for each patient is quite often tailored, because we take into factors such as how aggressive the patient's disease is, if they have any other physical impairments, and all those things will modify the way we approach each patient. So the changes in the type of drugs we give are important. We are better able to match patients and donors as well to make sure that we can choose better matched patients to reduce side effects. And also, we have better supportive care measures. So over the last 10 years, for example, we have far better and far stronger antibiotics on our hand, so that the actual risk of patients dying from infections now is far lower than what it used to be in the past, because we're able to come in far more quickly with antibiotics to treat them. So again, this is another slide showing the numbers of stem cell transplants worldwide and how there's been a steady increase in the number of yellow, which is the allogenic stem cell transplants, and autologous numbers have also been increasing slightly. Key differences as well is because we are able to do more transplants safely, the age of the patients who are being transplanted is getting higher as well. So in the past, 10 years ago, we probably wouldn't try to transplant patients above the age of 50, or we do it with a lot of trepidation because we're worried of the side effects. Increasingly now, we're offering transplantation to patients who are more than 60, and in very fit and selected cases, even patients who are in their 70s may benefit from a stem cell transplant. So the age of transplantation patients is increasing. But still, the main indication for stem cell transplant, allogenic stem cell transplant in particular, remains for acute leukemias. So if you look at this chart, the two bars on your left are leukemia, and that's the main indication for transplant. But if we're doing so many transplants, do they benefit? And this chart just shows you the outcomes from there. So this is summary worldwide, yeah, from all the different centers around the world, from a 4-year period, from 15-year period from 1997 to 2010. It shows that patients who are in remission at the time of transplant for acute leukemias, if you're less than 50 with a matched sibling donor, your 1-year survival is almost 80% now with a stem cell transplant. And even if you're a bit older and you have an unrelated donor, your survival chances are still approaching 60%. So overall, for acute leukemias, this procedure is becoming safer, and the outcomes are getting better with time. And just to show an example, if I may share this, I've asked the patient permission for this. If we could maybe, I know some of you are taking photos, would you mind not taking photos when I show you a picture of the patient's face afterwards from there? But he's happy, he's given me permission to show this. But for example, this is the first case we transplanted since I've come to join the group, which was done at the beginning of the year. It's a 45-year-old man from Bahrain who had AML, was in first remission. As I said, I showed you earlier on, these patients do well. Came in to Singapore after intensive chemotherapy. We gave him what we call a moderately intensive conditioning regimen, so not too much chemotherapy for that, because he was a bit older. He tolerated the transplant extremely well. And the important thing I want to show you here, how things have changed. In the past, on average, patients stay for 28 days. This patient was in hospital, had his chemo, had his stem cell transplant, and was out within 18 days. So he performed very well. Not all patients do that well. But when we select the right patients who are doing very well beforehand, we're able to minimize the stay in which they're in hospital. That keeps the costs down, but we also can do it effectively with good outcomes. So he's now almost 2.5 months out of the transplant. He's still in remission at the moment from that point of view, and he's doing well. But just an example to say, as the technology changes, we're able to reduce the toxicity for patients. We're trying to keep them in for less if possible, but still make sure that the results are good. Expanding accessibility. That's another challenge we have, particularly in this region. Why is that so? Because we need to find the right donor if we want to do an allergenic transplant. And if you're looking at family members, we all get one set of genes from our parent and one set of genes from one from our dad, one from our mom. The chances of us having a match between us and a sibling is usually 25%. Okay? But if you don't have a big family, the chances of you getting a sibling donor is sometimes very low from there. If you have only one child, it's a 25% chance. If you don't have that, conventionally, we will look for an unrelated donor. And we can look for this either in the Singapore registry or a worldwide registry. But unfortunately, when it comes to this, ethnicity plays a big determining factor in how your chances of finding a donor. So if you're Caucasian, the chances of finding an unrelated donor are anything from 60 to 70%. It's a high chance. Partly this is reflected due to the reason that there are a lot of very large registries around the world which have many Caucasian people who have donated. So, for example, the European registries and the American registries are extremely large, so your chances of finding donor are extremely high. If you're Asian though, and if you're, let's say, Malay or Indian, the chances of finding a donor are extremely low. And one of the key reasons for that is that there are very few registries with many Malays or Indians in there. And this is due to cultural reasons, due to the lack of registries in certain countries. So because of that, quite often it's frustrating, and in the past that's been the case where we get patients who come who need a transplant, we prepare them and they're ready for a transplant. Sometimes we cannot find a donor so that they can benefit from a stem cell transplant. So that's one of the big challenges we've had. How do we make sure that every patient who needs a transplant can get a transplant from there? So one of the things we're doing, cord blood transplantation, I'm not going to touch on today, but one of the other initiatives we've done, both in the adult and pediatric program for a while now, is we look at haploidentical stem cell transplants. And what do I mean by haploidentical stem cell transplants? In the last 5 to 10 years in the field of transplantation, there have been quite big developments in understanding the immunology and the biology of transplants. So now we can actually quite safely offer transplants using a mismatched donor. A mismatched donor, where the donor may be up to a 50% mismatch from there. And that's what we're doing more and more. And what's the significance of that? The key significance is if you only need a 50% matched donor, for every child, your parent is automatically a donor, because you get half of your genetic material from one parent. Likewise, if you're a parent and you have children, every one of your children will automatically be a potential donor for you, because you always give half of your genetic material to your children. So for many parts of the world, or this region particularly, where you have slightly bigger families, automatically you will be able to get a donor. So your chances of getting donor increase significantly from there. So this is another case I want to show. So this is a patient, a Russian patient, 26-year-old, who was diagnosed with acute leukemia and came to see me after being treated in Russia, where she actually had very resistant disease. So she was treated with 7 courses of intensive chemotherapy and her body was battered, but at the same time, she had a failed response. And with modification of drugs we can give, we were able to find the donor, which was a sister, who was a 50% match. And she tolerated the transplant well. And actually, she's now in good remission for the first time. And this is after 6 months. So not all patients respond this well, but this is just to show you that haploidentical transplants is a technology that I think as a group we're comfortable, we're safe with. We know that it can benefit many patients from there increasingly. So this is, again, one of the key initiatives we look at in terms of allowing more patients from around the region to be able to be transplanted if they need to from there. So I'm just going to touch a very little bit about some of the newer stuff coming through in terms of cellular therapy, partly because many of these things are not quite ready for mainstream yet. And there has been a lot of news, a lot of features in the news over the last year about what we call designer cellular therapy. Okay, and this is a patient in America who benefited from it. And it's a type of technology. I know this is a quite technical slide, but it's called CAR technology, so chimeric antigen receptors. So one of the things that we recognize in the field of transplantation is that when you transplant someone and you put cells from a donor into a patient, you are hoping that the donor cells will be able to recognize the leukemia and fight them. But you can't always be sure that these donor cells will home in and fight the leukemia from there. So increasingly, several groups, what they've looked at is that if you can create a receptor, a designer receptor, which is specifically targeted to your leukemia or your lymphoma, okay? And if you can, after you design this receptor, if you can put these receptors onto the surface of your donor cells from there. So then you have a transplant of donor cells which are specifically targeted towards a particular type of leukemia. So these are called, this is a designer chimeric antigen receptors. So this is the next wave of technology that's coming through, where rather than just giving a stem cell transplant, we modify the donor stem cells so that they can home in on a target from there. So there's been a lot of press on that. Trials have been coming through which shows a lot of promise, and it's actually becoming a commercialized product quite soon. So hopefully, as the studies come through, we may be able to gain access to that. So this is, again, another aspect of stem cell transplantation where, as we're going forward, we're trying to design and modify donor cells to become even more specific in how we fight leukemia. It is not all good. This type of treatment is associated with a lot of toxicity at the moment. Many patients end up having a lot of tumor lysis when they get the treatment and have to be in ICU. So it's not quite ready for mainstream yet. But I just thought I'd throw this in to give you a flavor of where the field is developing in the next 5 to 10 years. So finally, I just want to show you a few slides just to talk a bit about the PCC Transplant Team from there going forward. And this is a lead-in to the tour later on this afternoon. I think, as mentioned earlier on by MC, there are 4 members of the team. All of us are extremely experienced. We've done many transplants over the years. Many of us have been pioneers in the field of haploidentical cord blood transplants in the region. And we also, it's not just about the doctors. And that's what we always say. For a transplant to be successful, the doctors front the team. We like to be the public face, but actually behind us, we have to have a very good team of supportive staff. And that's one of the reasons why we all pulled together in PCC, because we are actually able to develop a very strong team of outpatient and inpatient nurses, but as well we have a whole team of dietitians, counselors to support the patients through the whole process. Because as I said, patients are in hospital for 4 to 6 weeks, and we need to support them. We have 3 facilities at the moment where patients are being transplanted: Mount E Novena, Mount E Orchard, Mount E Gleneagles. The pediatric cases are currently being done by Dr. Anselm Lee in Orchard. The adult transplants are being done in Gleneagles, but in the near future, our adult services are going to be focused on our new service in Novena. This is a picture of the Mount E Novena. We have dedicated outpatient facilities, which you'll get to see afterwards. This is a picture which you'll get to see of our transplant-specific wards. And finally, to summarize, I just want to say, in terms of our transplant service, our commitment there. And where there are several things we feel quite passionate about. Yeah. We want to deliver high-quality transplant care. That's most important from there. The patient safety, patient benefits most important. But we also are looking at developing and keeping abreast with the latest developments in the field so that our patients continue to be benefit and get the best care possible. But finally as well, I mean, that's why we've got the regional media as well as local media here. We also want to say that we also want to help. And many of us, when we travel abroad, we have networks with our local physicians in the region to make sure that care is continuous between the region, but also to provide an advisory role to help develop transplant in some areas where the countries may want to develop transplants. We are committed towards developing methods which are effective, but as well as cost effective. And finally, we want to make sure that as many patients can benefit from transplants as possible. So with that, I've just rounded up. Thank you very much for your time, and we'll be happy to take questions later on. Thank you.